Good afternoon, everyone. Thank you all so much for joining us today. I'm Robin Grant, Director of Public Policy and Advocacy for the National Consumer Voice for Quality Long-Term Care. I want to welcome all of you to this 8th webinar in our ongoing series entitled COVID-19 Advocating for Nursing Home Residents. So as you know, we've been having these weekly programs in order to keep everyone updated on the latest information and guidance, as well as actions at the state and federal levels that are related to COVID-19 and their impact on residents of long-term care facilities. Next slide, please, Libby. So I want to tell you a little bit about what we're going to focus on today. We have a number of issues we're going to cover. We're going to start by looking at how we can promote visitation between residents and families again in a safe and responsible way. And we're going to talk a bit about stimulus checks and making sure they're actually going to residents and not to the facility. We'll also touch briefly on yesterday's briefing in the House Select Committee on Coronavirus, in which our very own Eric Carlson from Justice and Aging testified. And then lastly, we'll share with you what we feel are some disturbing concerns that we've been hearing from residents. And at the end, of course, we'll spend the remaining time on questions and discussions, and then we'll get to as many questions as we can. So our speakers today, next slide, please. Sorry about that. So our speakers today are Lori Smetanka, Executive Director of Consumer Voice, and Toby Edelman, Senior Policy Attorney with the Center for Medicare Advocacy. So I need to go to the next slide. There, sorry, I think I'm a little one behind. So there you see our presenters for today. Before we begin, I want to cover just a few housekeeping details. Those of you who've been with us on all of these webinars know these by heart by now, I'm sure. But today's webinar is being recorded, and the slides can be downloaded from the chat box. So check out the chat box, and there's a link in there that you can click on. As always, the recording and slides will be emailed out to participants early next week. We will then also post them on the Consumer Voice website. And it's on the website that you'll find the recordings and slides from all the previous webinars that we've given. As we go through, we'd like to ask you to put your questions into the Q&A box that's on your control panel, and to save the chat box for making comments and having discussion among yourselves throughout the program. And then finally, all the lines are muted throughout the program, and then we'll, at the end, of course, get to as many questions as we can. So with that, we'll go ahead and get started. Next slide. So before Lori talks about reuniting residents and families, I wanted to say just a few words about the impact that this separation has had on residents. You know, as we've said before on these webinars, visitors have been banned from nursing homes since mid-March. And since that time, we know that a number of creative and different approaches have been used to connect residents and families, including, video visits with FaceTime or Skype. We've seen message boards from residents to families. And we have a new thing now, which is window visits. And while these approaches are great, they are not the same as an in-person visit. We're hearing from residents, family members, and ombudsmen across the country that the pandemic has taken a terrible toll on residents, and not just on the physical health of residents, but on their emotional health as well. Residents are afraid, they're anxious, they're depressed, sad, worried, confused, concerned, and angry. Families are telling us that residents feel abandoned and lonely. And ombudsmen report that many residents are now feeling such despair that some of them really seem to be giving up. And in fact, one state ombudsman, I think, put it very starkly. She said that residents are literally dying from isolation. And I have to say that now her words actually have been supported by evidence, because just today in a TV story that came out of Minnesota, we actually heard that in the case of 2 residents so far, the secondary cause of death that was officially listed on the death certificates was, and I'm quoting, social isolation / failure to thrive related to COVID-19 restrictions. So you really can die of a broken heart. So there is growing recognition that something has to be done to permit residents and families to visit again, some way, somehow. And with that, I'm going to turn things over to Lori, who will talk about some of the ways and some of the hows. Lori.
Great. Thank you so much, Robin. And it really is a stark issue that I think that we're dealing with here. So next slide, please, Libby. So as we all know, back in March when the pandemic started its journey around the world and through this country, almost immediately CMS issued guidance to issue a ban on visitation, group activities, and communal dining as a means of protecting residents. The spread through facilities obviously has been like wildfire in many places, and severe actions needed to be taken to try and stem the spread. So the results, as we know, were to stop the visits. Families, friends, volunteers, ombudsmen, non-essential health care providers, even surveyors have been instructed to limit their on-site visits and to look at whether they could do virtual inspections or other visits. And very few exceptions have been permitted to that in compassionate care situations is one, and we'll talk about that a little bit later. But essentially, no one has been going in and out of nursing homes other than essential healthcare providers. So next slide, Libby. So since now it's been 3 months since nursing homes in our society essentially has been closed, there's increasing pressure to allow families in to visit with residents, to see residents. There are deep concerns, as Robin mentioned, about the decline that they're seeing in their loved ones. There's the pain that family members are experiencing of not being able to be with their loved ones who have been going through the dying process or have been dying. And sometimes it's as a result of the isolation, but even just they're coming to the end of their lives. And with the push for reopening our society and our communities, that pressure is also spilling over into long-term care facilities. It's, people are saying it's time that we find a way to reopen facilities and allow family members back in. So you'll recall that CMS released some guidance a few weeks ago, which we covered more in depth on a previous webinar, and the recording is on the Consumer Voice website if you'd like to go back and listen to that or look at the slides. And essentially, that guidance provided for 3 phases of reopening. It provided for states to take into account certain considerations, such as the community case status of the spread of COVID, the nursing home case status, how many incidences or cases of COVID were existing or prevalent in the community and then in the nursing home, what the staffing looked like in facilities, whether there was adequate access to protective personal equipment or testing, the use of universal source controls such as social distancing and wearing of masks and other protections that are being put into place in our communities to help prevent the spread, and also local hospital capacity. Those are factors that helped indicate whether or not a community should move from one phase to the next, and that then would influence whether a nursing home could also move from one phase to the next. And CMS also suggested that prior to relaxing restrictions that there should be baseline testing for all residents and staff, that surveyors should go in and survey facilities that had had significant outbreaks. And they also recommended that nursing homes reopening, so to speak, should lag behind a community's reopening by about 14 days, thinking that if the spread of the virus had been stemmed in the community, that there was less likelihood of it continuing to spread in the nursing homes. But we know that there have been some issues with what has been released by CMS. First of all, we know that there are very significant challenges in many states and communities to obtaining the personal protective equipment or PPE and for testing for residents and staff. Despite the fact that more and more states are requiring the testing, it still is not universally happening, which obviously would affect the ability of the nursing home to open. And CMS also said these are really just guidelines that states and communities should really set their own processes and procedures and guidance for how they should be reopening. And so that's a bit of a challenge as well, because that leads to a lot of variety among how this is going to be happening across the states. So next slide, please. So we are actually seeing states developing their own guidelines right now for allowing visitors. You'll see a handful of states that are there that have issued some form of guidance, whether it be a broader approach that is following maybe a phased-in approach similar to what CMS is recommending. Some states are being very focused in what they're allowing right now, maybe just outdoor visits in some specific areas. But states I know are working on this. A number of states are working on it. They're pulling working groups together and task forces made up of the emergency response and the departments of health and others at the providers and others at the state level who are working on developing what this guidance should look like in order to allow families back in. We know that a few of the states actually just earlier this week started outdoor visits for the first time now that the weather is getting nice. That's been an option that's been made available. But states, I think, are also really struggling with what this process should look like and are trying to be very careful about it. One of the things that we really are recommending is that any of these working groups should include consumer representation, residents and families, as well as ombudsmen and citizen advocates as part of this process. We know that in a number of states that is occurring, but that's not universally true. And so as ombudsmen and residents and families and advocates, we would encourage you to ask for a place at the table as this guidance is being put forward and being developed so that you can have input into what this should look like. Next slide, please, Libby. So we at the Consumer Voice have been talking to a number of ombudsmen and advocates and residents and families across the country and thinking about what makes sense in terms of what guidance should be provided to states, what the process should look like for reopening. And we think that the guidance should include a number of elements. For example, it really does need to focus on balancing the need for safety and to stop the spread of the virus with the need for connection and support that residents and family members need. So how do we do that? I mean, we need to obviously look at evaluating the conditions in the community and the facility and the prevalence of the spread of the virus. That obviously is very important. And maybe they need to look at a measured approach for allowing visitors back in, not just throwing the doors open, but having a process for prioritizing the types of visits that can be established and what those processes should look like. But we know that certainly with the way that many residents are suffering, experiencing significant decline in their condition and even dying, and also that family members are providing many of the critical supports for those residents who are struggling the most during this process. it really is incumbent upon communities, states, and facilities to find that balance and find a common sense approach to allowing visitors back in to provide supports and to support the residents. We think that any guidance really does need to emphasize individual resident needs, including the need for compassionate care, and we'll talk about that in a little bit. But as we're looking at, there shouldn't be arbitrary procedures that are established, that they should be looking at what is in the best interest of the residents broadly, how can accommodations be made that meets both the needs of the residents and families, as well as the resources that are available at the facility, and look at some common sense approaches. Facilities really should have policies and procedures in place for allowing family members in for compassionate care situations, as well as how it would begin allowing other visitors in, what procedures would need to be followed for visitors to come in, and how it will balance safety during this process, because obviously that is really key. And one thing that we're not seeing so much is some oversight responsibility on the part of the state with respect to how these facility plans are going to be implemented and the steps that are going to be taken to allow support persons and other visitors back in a way that supports the residents' best interest. We think there does need to be some oversight of the processes and some accountability for establishing and implementing procedures in a timely manner. Throughout this whole process, from the closing of facilities, the banning of visitation, as well as thinking about what the reopening processes has looking like, a significant amount of discretion has been given to facilities around when and how it will allow people in. And certainly there are some very facility specific situations that need to be taken into account, but we're seeing, unfortunately, very extreme unevenness in what policies look like, how they're being implemented, and not always the best interests of residents being taken into account in these processes. So the other thing is that without accountability, there aren't many incentives for facilities to prioritize reopening. We have been hearing that many of them consider the reopening process to be somewhat burdensome, and we are concerned that there might be some unreasonable delays in the processes without some additional accountability. Next slide, please, Libby. The issue of compassionate care has been one that has been full of frustration and confusion for residents and families and ombudsmen and others who have been working in this field. And really, like, what is it? What is compassionate care and when should it be applied? And in the guidance that CMS has provided, what it says is what you see on the screen, that facilities should restrict visitation except for certain compassionate care situations, such as an end-of-life situation. And that's really all it has said. We have certainly been asking for some additional guidance and examples from CMS, and we're really interested in hearing from all of you about some other examples that you may be seeing and coming across, so that we can share those and hopefully have good implementation of different compassionate care examples across the country. Clearly, this is a question that has come up to CMS a lot, and in their frequently asked questions around their guidance, they did address this in question number 4. And if you'll look at the language in red there, it says an example of compassionate care is a situation where one is receiving hospice and their health status is sharply declining, or when a resident is not enrolled in hospice, but their health status has sharply declined. So I think that's CMS's way of saying that it does not only apply to end of life and situations or when a person is enrolled in hospice, and certainly that is something they have specifically told to us in a meeting, that it does not only apply to end of life situations. Next slide, please, Libby. But we do think that more clarity is needed, both in terms of when it applies and as well as how to implement it in a way that's meaningful for residents and families, including an end of life, because we are seeing very wide variations in even the end of life applications of compassionate care. In some cases, families are not being allowed in until the very end of the active dying process. Some of them are being told they can only have one visit with the person, and oftentimes that they're not being told that until they get on site and are having to make decisions about whether or not they use that as their one visit with their family member, being told they can only stay for a very short period of time with their family member who are dying. So because this has been such a challenging area, we have been seeing that states are starting to look at this because of the frustrations that they're hearing from family members and ombudsmen and other advocates. And in fact, one state has started developing some language around end of life, saying that the facility should notify family members even several days or up to a week in advance of when a substantial change in condition has occurred and end of life is approaching, and to not wait until the active dying process in order to allow visitors. So that is something that, as you're working on guidance in your states, you should really be looking at how to help provide better guidance around that. But the compassionate care situation should apply to other scenarios as well, such as when a resident is experiencing significant decline or distress, or has relied on a family member or other support person for necessary assistance that they're not otherwise getting. Some examples that we're regularly hearing about include individuals with dementia or significant behavioral health needs who are experiencing deep decline in function or great distress because of the effects of COVID. And often these individuals have relied on family members or support persons, for example, to help calm them down or de-escalate expressions of agitation or provide other critical assistance that they're not otherwise getting without their family member being on site. And even in other situations where we're hearing of great physical decline, weight loss, and failure to thrive, that had, because of those individuals having previously relied on family members to help them, for example, with eating or drinking, and those supports are not being made available to them in similar situations. I could even apply this to a personal experience. I remember visiting a great aunt in a nursing home when she was at the later stages of her life and had advanced dementia, and it took her more than 30 minutes to eat a meal. And my cousin, her daughter, would go in every single day, twice a day, to feed her her meals. It's very difficult for a staff person right now to sit and spend 30 minutes with an individual resident to help them eat. And we know that with the shortage of staff that's occurring in many facilities, which is exacerbated during this time of COVID, we just have real concerns that residents are getting the individualized care that they need in all situations. So next slide, Libby. So in addition to the state guidelines and that we just talked about, there, I think, are certain there are certain policies that facilities need to put into place as they look at reopening for visitors. And next slide, please. And first, related to that is the process that they're going to use for allowing visitors in. What is that process going to look like? And that certainly is going to have some impact on, again, the prevalence in the facility and the prevalence in the community, the availability of PPE, those factors that we had talked about before, the testing. But we really do want to see facilities prioritizing compassionate care situations, allowing support persons, essential family caregivers. There are different terms that are starting to be used for those individuals that are providing the really necessary compassionate care support that residents need in order to stem the decline that we're seeing in many folks, or provide the necessary services that assist them. And so one example that we came across just this week is from Indiana, who has some essential family caregiver guidelines that they have released, where, as you'll see on the slide, it talks about family members and caregivers who, prior to visitor restrictions, had regularly been engaged with the resident at least 2 or more times per week, providing companionship or assisting with other types of one-on-one activities that the resident needed. So there really should be some prioritization for allowing people who are providing such compassionate care into facilities and starting right away. This is not something that we really should be waiting for. The residents who need the compassionate care are the ones that are most at risk for decline and death. And so those individuals really need some immediate supports. But then the processes that facilities are developing really need to include how they are going to be allowing other visitors in. What is the process that they're going to be using, and establishing the criteria for that. And we can talk about some of that in just a minute, but it shouldn't be arbitrary. There should be some good standards that are communicated well to families, to residents, to others who are looking to re-enter into the facility. Not to be forgotten is that they should be talking to residents about who they want as visitors, who they want to be brought in as designated support persons if they're able to communicate that. And accommodation should be made for all residents. A lot of what we're seeing is that only individuals who have either tested negatively or are not showing symptoms and having been exposed are the only ones who are having allowable either compassionate care visits or even any sort of visits. But all residents need some level of interaction and support, and so they should be looking at how to provide support to all residents in the facility. Next slide, please. Other factors that the facility should be incorporating into policies and procedures that should be developed around allowing visitors back in is what screening processes are going to be implemented. We're seeing regularly that temperatures are taken, they're being asked about symptoms, they're being asked to sign in. Those are things that are occurring right now for staff and essential healthcare workers, and they can be applied to family members or support people that are coming in as well. The use of protective personal equipment would be required, masks or face coverings during each visit, visitors washing their hands and using sanitizers. And to the extent that testing is available, testing should be one of the policies or procedures that is put into place. But understanding that testing still is not available in all areas, other processes should be put into place as well, particularly with respect to the use of PPE, sanitizing their hands, using social distancing, screening, those types of things in order to allow people back into facilities. Next slide, please, Libby. And then the facility really should be spelling out reasonable accommodations for allowing visits with family members, with other visitors that the residents choose to have as visitors, including what days and times are they going to be making visitation available. We would encourage that sometimes should be made available every day and at different times during the day, so that that fits in with visitors' schedules as well as resident schedules. Looking at where designated locations would be for visits in the residence room. We're seeing outdoor visits, which should include adequate shade covering, being put into effect, as I mentioned earlier, even just this week. Window visits, we have been seeing those, and accommodations should be made when possible for such visits, or other designated rooms in the facility as available. But the facility really needs to be thinking about how many visitors they can accommodate based on social distancing, based on the needs of the residents, and also based on the available supports that can be provided as necessary. And to put some processes in place for that, they should be communicating what the procedures are to not only residents and family members, but be sharing this information with ombudsman programs as well as the licensing agencies, so that everyone is on the same page about it, so that folks know what to expect when they are coming in for a visit, and they know what standards they are also going to be held to when they get on site in order to visit with their loved ones. And I think a couple other things related to this is arranging for privacy during the visits. That's really important. Residents should have the right to visit privately with their family members, and also to arrange for a staff person who helps facilitate this process. I would certainly argue that activities professionals and social workers, or even some of the resources that the facilities are getting through the COVID emergency relief funds, should be dedicated to facilitating visits with residents and families during this process. So those are some of the things that we think should be definitely included in the procedures that facilities would be implementing, and that we think the state should be holding them accountable to. So with that, I'm going to turn it over to Toby, who's going to talk to us about the stimulus checks, and I'll be back later to talk about some other things. Thanks, Toby.
Thank you, Lori. The stimulus checks, as we know, were authorized by Congress in the CARES Act. They're called economic impact payments, sometimes stimulus checks, and they're $1,200 generally for an individual. In mid-May, the Federal Trade Commission issued an alert saying that states had received some reports that some nursing facilities and some assisted living facilities were telling their residents who used Medicaid that they needed to sign the checks over to those facilities. Next slide, please. So what we saw yesterday was a press release from the Centers for Medicare and Medicaid Services about nursing home residents' right to retain federal economic incentive payments. So that's a link to yesterday's press release. Next slide, please. What CMS says is that it's heard allegations, but it has not received any specific complaints about facilities seizing residents' checks. Next slide, please. So what their position is that if the facility is doing that, if a nursing facility is taking the resident's $1,200 check, that violates two regulatory provisions. It violates the Rule 483.12 because it's a misappropriation of the resident's property. And then if the facility is requiring, not taking the money directly, but requiring the resident to deposit the check with the facility, then that would violate Section 483.10, which is the right to manage one's own financial affairs. Next slide, please. What CMS says people should do is either file a complaint with the state survey agency, and then the investigators, CMS and state investigators, will make referrals to the state attorneys general if they find a violation. Or CMS recommends that people who have been asked to give the check to the facility or to deposit it with the facility, that such people, residents, could file a complaint with the state attorney general. Next slide, please. Now, this seems very odd to me because if there are no complaints, why are we getting an FTC alert, although they seem to think there have been problems, and why is CMS issuing a press release on this topic? But in any event, if anybody has been a victim of this practice or has more information about it, please let me know. There are some reporters who would like to talk to people if they had some specific examples. So next slide, please. That's it for the stimulus checks. Yesterday, June 11th, the Select Subcommittee on COVID of the House Committee on Oversight and Reform held a hearing called The Devastating Impact, a briefing, The Devastating Impact of the Coronavirus Crisis in America's Nursing Homes. And I think it was quite fascinating and worth watching. It was a little bit more than 2 hours. It's worth looking at, especially if you've never been to a congressional hearing. And I think what it would show you with the extraordinarily partisan nature of the members of Congress and what they were doing, you'll see why it is so difficult to get anything done in Congress, especially these days. I think we've never seen anything quite as partisan as yesterday's briefing. First, there's an opening statement by the chairman, Jim Clyburn. Then there was an opening statement by the ranking member, Steve Scalise. There were 5 witnesses who spoke. Allison Lally is the daughter of a resident in Louisiana who died. Chris Brown, certified nurse assistant from Chicago, has been a CNA for 10 years. Then Eric Carlson of Justice and Aging, who of course, absolutely not surprisingly, did an excellent, excellent job and got a number of important points in, both in his 5-minute opening statement and in answer to questions. He did get some questions and he got good points in response. So he spoke about the history of poor care in nursing homes, the history of insufficient staffing, the weak enforcement system, and the need for better accountability. So Eric was the third witness. The fourth was Phil Kirpin from American Commitment, an organization we had actually never heard of before. And finally, David Grabowski from Harvard Medical School. He's also a member of the Medicare Payment Advisory Commission. And he is the American Healthcare Association's lead academic that they rely on to speak on their behalf about what they are concerned about. So after each of the 5 witnesses made a 5-minute opening statement, then the members of the select committee got to answer questions in 5-minute increments themselves, alternating between Democrats and Republicans. The Republicans in particular used their time to criticize Democratic governors, especially in New York and Michigan, for requiring facilities to admit COVID positive people. And they were blaming those governors and those states for a lot of deaths in nursing homes. Some of them never got to any questions. They just used their 5 minutes entirely to rant about how bad the Democratic governors were. They also criticized the media. The Democrats, for their part, countered and said these were national problems. It's not a problem of red states or blue states. Residents had died in every state in the country, and it shouldn't be so partisan. But there were some questions, and generally I think there are 3 things that came across quite loud and clear in this briefing. First, problems of insufficient staffing were serious problems before COVID. This is not new. It's been a problem for a long time. That was clear by Ms. Lally, by Mr. Brown, by Eric, and even Grabowski agreed that there were problems with staffing, although he generally blamed the lack of staffing on inadequate Medicaid reimbursement, which is one of the main arguments. I just would say that Dr. Grabowski also did not accept the Republican statement that the Democratic governors were at fault. He said COVID is not because of state policies. He said what the American Healthcare Association has been saying repeatedly, that it's a question of geography. If there's coronavirus in the community, there will be coronavirus in the nursing home. It's not really related to the quality of care or staffing levels or prior infection control deficiencies in facilities. So he made that point too, but Dr. Grabowski agreed with the other witnesses that insufficient staffing is a problem in nursing homes. The second big point that came across, I think, was that the federal government needs to take a leading role, and it hasn't. It has failed pretty miserably. We need the federal government to do better testing, providing PPE, and making sure there's adequate staffing. And then the third point that I thought was quite strong was primarily made by Dr. Grabowski, and that is that the data are very, very poor. CMS on May 8th in the interim final rule that we talked about maybe a week or so ago, CMS, or longer ago than that, CMS has required facilities to report to CDC about COVID deaths from May 8th going forward, not going back. And what Dr. Grabowski said is that's not good enough. Good public health requires good data. We don't have good data. Even with the problems in the data that were submitted and released last week by CMS, even accepting that there are going to be some problems in a new system, even so, he said we need to go back and get all the data. So lack of staffing, the need for a strong federal role, and poor data were important themes. And I think just as in many kinds of situations like this, the people who were closest to the issue, the daughter and the nurse aide, were incredibly powerful. Ms. Lally described her mother being admitted to the nursing home December 31st, 2019, 5 minutes from their home so they could visit regularly. And then she described almost on a day-to-day basis what happened to her mother starting in mid-March when families were barred. She described her mother looking disheveled, her mother saying that she hadn't been fed, the facility refusing to communicate with the daughter when she was trying to find out what was going on. They were not telling her accurately whether there was coronavirus in the nursing home or not. She was very, very, it was very powerful and emotional to listen to her. Finally, her mother was sent to the hospital and she died alone in the hospital in April. That was powerful and very, very troubling. Then Chris Brown, the nurse aide, talked about the absence of, the inadequate staffing levels, inadequate PPE, insufficient testing. He said he himself has not yet been tested for COVID-19, even though he goes to work every day. He said he moved out of the family home because his grandmother is there, and he was worried that, if he had it, he certainly didn't want to give it to her. He described teenagers being sent to his facility to work. He said they're supposed to help, but they're not helpful because they're not really trained. They are not qualified to provide direct care to residents. So the most that some of them can do is just give a resident a tray. They really can't do anything else because they're not trained. They don't know how to do it. So he's been working 10 years as a nurse aide. He got interested in this field because he took care of his grandfather 10 years ago. So that was a pretty moving statement. And he said he himself now makes $13.90 an hour. So that was the hearing. It was fascinating. If you have time and you're interested to watch a little bit, I would urge people to do that. And I really do want to thank Eric again for presenting advocates' position so very strongly and effectively at the briefing yesterday, especially knowing he had maybe less than 48 hours to get ready after he was invited. So thank you, Eric, for doing a great job. And back now to you, Lori.
Thanks, Toby. So we wanted to raise some of the concerns that we're hearing a lot from some residents. Some of us from the Consumer Voice had a call with some residents last week, and several of them raised a number of issues that they are experiencing, which again came up on another call that we had with some other advocates also earlier this week. And we wanted to raise them because we would think that since we're hearing them from all areas, that maybe some of you are experiencing them as well and might want some additional strategies for responding to them. So next slide, Libby. So first, just want to remind folks that despite the fact that we're in the pandemic, residents still have rights in long-term care facilities. While there have been some suspensions of some of the rights, such as the visitation and even some access to group activities and things like that, generally the rights of residents are still intact, and they should still be receiving care and services to attain their highest levels of well-being. They should still be participating in the development and implementation of person-centered care plans. They should be making decisions about their care now and in the future, including things related to advanced directives and how they might want to receive care in the future. They still have the right to be free from abuse, neglect, and exploitation, and to raise grievances that they may have with the facility without fear of discrimination. And also, despite the fact that there have been some waivers to transfers that are for cohorting residents based on COVID status, the general protections for transfer and discharge for every other purpose are still intact. And so we want to just remind folks of that, because we are hearing a number of violations that are existing related to these things. And so as residents or families have concerns about some of the care that they're receiving, they still can be filing complaints with ombudsman programs and turning to them for assistance, as well as their licensing agencies, even though the surveys are not fully being done at this point, or the complaint investigations by surveyors, we still would recommend you filing complaints that you may have. So next slide, Libby. So one of the concerns that we've heard raised multiple times is that even now, 3 months in, many residents are not only being asked to remain in their rooms, but that the doors are being closed in the facilities, that they're closed at all times, 24 hours a day, other than a staff person coming in or out. And one resident that we spoke to last week talked about her being claustrophobic and how that it's really affecting her well-being. And she just feels very closed in situations like that. And I found yesterday a blast that was sent out by the Connecticut Department of Health to facilities in Connecticut that I think can be replicated across the country. And they stated that there's no policy stating that resident room doors have to remain closed, that there is no risk to keeping doors open, even with suspected or confirmed COVID-19, unless there are aerosol generating procedures that are being conducted, like respiratory types of treatments that are being conducted. Otherwise, there's no reason why the doors can't remain open. And so we would really encourage that be looked at and that you be advocating for doors to be opened. Next slide, Libby. Another really problematic situation that we were hearing about are residents who are under no circumstances being allowed to leave their rooms, even to get a shower. Some of the residents we talked to last week literally had not had a shower in 3 months, and they are very frustrated by that. And so certainly, while the CDC guidance is that residents should be remaining in their rooms to the greatest extent possible, there are provisions for if a resident does need to leave their room, such as wearing a face mask, performing hand hygiene, maybe not being out, everyone out in the hallway at the same time, but certainly going from a room to a shower room should be something that can be accommodated so that residents can be given showers on a regular basis. And so that is something that is very troubling to hear, that there are a number of facilities that are not even making those accommodations for residents. And I think that it's an area that we can be advocating for to help support residents in these areas. And then next slide, Libby. Other issues that were raised by some of the residents, and even that some of you have raised on previous webinars, are some facilities that have been banning window visits in the facilities, which again is something that we talked about earlier that is being obviously allowed in so many areas. And I think that for those places that may be banning those visits, it's due to maybe some of the frustrations for not having good processes in place for how they should be occurring and how to be communicating that with families on how they can be done successfully. So we really would encourage good communication between residents, family members, and the facility about how to successfully do these window visits. And there are lots of you out there, I know, that are doing them. We've seen so many pictures and articles and videos about the visits being done, that for a facility to say that they're just going to ban them right now really seems to be unacceptable. So that is an area that I think we can do some more advocacy around. And the last point that I really wanted to highlight today that residents were raising was the fact that they're not even being allowed packages or food delivery or things like that during this pandemic. And again, there's no prohibition on them receiving mail, on them receiving packages, or receiving food delivery. And that's another area that is being applied so inconsistently across facilities and across the country that I think it's an area that we can do some more advocacy around at the individual level and help to support residents because they are feeling very isolated, very alone, and none of us would like to be just kept in our own rooms with doors closed, no access to window visits, or even in some cases fresh air, and no hope of packages or letters or some other treats that they may want to have delivered to them or families may want to send. So I do think that there's good advocacy that can be done in each of these areas. So I just want to touch upon a few things that are happening at Consumer Voice that you may want to know about. So next slide, Libby. First, I'd like to just remind you that we have a whole range of resources on our website where you can get all of the CMS guidance. You can get a lot of information for families and advocacy that can be done, that you could, the access to the webinars and the slides are all available there. So please look at our website for some additional information that I think you would find helpful. Next slide, please. We also started on our Family COVID webpage the option for folks to share their stories about what you or your loved one are experiencing in a long-term care facility during this process. So we would really encourage you to go and tell us what the good and the bad of what it is that you're experiencing. We are finding these to be very useful in the advocacy that is being done. Obviously, your contact information would never be shared without your permission, but we would encourage you to share the experiences of your loved one during this COVID crisis. Next slide, please. Next week, there's going to be a webinar for family members on advocating for their loved ones and things that they can do to support their loved ones and other residents in facilities. So watch for registration about that, and we hope that you'll join us. And next slide, Libby. Finally, we launched this week the theme for Residents' Rights Month 2020. The theme is Connection Matters. We've seen the importance of connection during this crisis, and it's one where you can find not only activities on our website, but also ways that residents can also engage in not only sharing their story, but what connection means to them as part of our Residents' Voice Challenge. So we would encourage you to check out our website for Residents' Rights Month materials. So with that, I'm going to turn it back over to Robin, who will lead us through Q&A.
Thank you, Lori and Toby, for your excellent presentations that I think really highlight some of the urgent needs of residents and the need for continued strong advocacy. So I think we have some time for some questions, and I guess I'll turn to Jocelyn Bogdan and Sam Brooks to let us know if there are any questions for our presenters.
Sure, Robin, thanks. A couple of different people asked, in terms of families reuniting with their loved ones, do families have the right to just take their loved ones out of the facility for a while and then bring them back? They pointed out that a resident should have the same rights in terms of a lot of these orders that people are following in different states as the general public. So how is this different for residents based on the fact they're in congregate living situations, and what rights do they have to leave and come back, and what does that look like for them?
So this is Robin. I'll take an initial stab at it. So I wish that I could say quite clearly, you know, residents have the right to come back. It's their home. What we are seeing is that when residents leave, there have been times when they want to come back and the facility has basically discharged them. And the concern here is that the facility doesn't really know where the resident has been, if the resident you know, has been wearing a mask, if the resident has been exposed to the virus. And so it is a concern and a possible threat to the health of other residents and the staff in the facility. So I guess it's a long way of saying it's not, we don't have a concrete answer for that at this point in time. I don't know what my colleagues might say to that. I wish I had a better answer.
This is Eric. I agree with you, Robin. The legal right is probably relatively clear, but like Robin pointed out, there's some practical issues and some real life concerns about, given how important it is to keep the virus out of facilities. There are some issues presented by people who leave and come back without much accountability over what happened in the meantime. So along with Robin, I'm sorry to give such a an answer that doesn't provide real clear advice that you'd want. But I think that's where it sits right now. There's the legal rights, but there are also some real life realities that unavoidably are brought in and are considered.
This is Toby. Do we think this is an area that we should be asking to get some policies on? that, you know, is it just totally left up to the facility to say, no, you are here and you can't leave, and if you leave, you can't come back? Or are there some standards that might, you know, say what would happen in these circumstances? I certainly understand what both of you have just said, but I'm also troubled about, you know, just letting it happen without saying we need some better standard of, you know, what is the policy, what should be the policy, what are the rules, because it might be somebody just going to go sit outside, and if they don't have outside visiting yet, suppose the facility hasn't done that, but that's all the family wants to do, so they haven't gone anywhere, they haven't touched anything, they're not, you know, they're wearing masks, they have social distancing, all those things, then people should be able to come back in. That seems different from a family, you know, from a resident leaving for a week and then wanting to come back.
Well, Toby,
Yeah.
I think that is a good point, and I think that it could certainly be worthwhile to see if to ask CMS if they would issue some guidance, at least maybe some clarification. So we could perhaps have some more consistency, and it's not so totally arbitrary from one facility to the next. I guess advocates in the state could also turn to their state Department of Health to see if perhaps some guidance could be developed. I guess part of the issue is how, you know, just do you know for sure that somebody has been wearing a mask and has been social distancing and that kind of thing. So,
well, maybe it's something that needs to be included in the reopening policies, you know, that people might be trying to go home for a few days and see if it works, or I just think it's something we would want to see some policies on, and not just each facility decides completely on its own.
anybody have anything else they'd like to add to that before we go on to another question?
Just
Another question that has maybe a difficult answer.
Yeah, Robin, just 10 seconds. On
Yes,
an individual note that residents would be well advised to have even in the absence of guidance, to have the conversation with the facility, maybe consult with the ombudsman, see if there's a way to collaboratively figure it out and assuage some of the facility's concerns. So they're easy to say from this distance, but there may be a way to deal with it at that level, but I also hear what folks are saying about the need for broader system-wide guidance as well.
And I'll just build on that and recommend that perhaps, Eric, I think that's a great idea for residents to have a conversation. This might be something a family council could raise as well, and maybe work with the facility and with residents to come up with something. All right, how about another question?
Sure. A couple people actually asked about advocating, and one person just asked, one person just said that they heard a lot of the problems and needs on the webinar today, but they're still not really sure how to advocate. At the same time, a few people were asking about how they can advocate for assisted living facilities that don't fall under some of the CMS guidance. And so I thought it's a pretty general question, but I would throw it out there if anyone has any quick steps or ideas for people.
Go ahead. Go ahead, Lori. I think that was Lori.
Well, okay, I'll start, and then would love to have other people add in. So I think that there are a number of things that can be done. I think if you're working at if you're a family member or resident or ombudsman or working at the facility level, there's some advocacy that can be done there in terms of talking through what are some common sense approaches to the issues that we're dealing with, hearing what some of the concerns are that might be raised, and brainstorming solutions to them. I think that just having blanket no's or blanket bans on things is not an appropriate answer, and is certainly not a way to provide individualized care for people. So, so that is something that I think can be done at the facility level. Certainly working with your ombudsman programs to raise concerns that can be also raised at the community level or the state level as different policies are being put into place, I think is another thing that can be done. So contacting your state departments of health, for example, or working with advocacy programs in your state, whether they're citizen advocacy groups or ombudsman programs, or even your local, your state AARP chapters are doing a lot of advocacy around nursing home and long-term care issues right now, providing support to each of them in terms of being involved as they are doing their own advocacy, providing input to them on some of the things that you're seeing, and offering to help them in different areas, I think is important. But also raising issues that you're seeing with policymakers, not only at the state level, but also at the national level, I think is important. Letting your Congress people and state legislators know what are the issues that you're seeing in facilities and what you think should be happening. How do you have solutions that you can be proposing as well, or ways that you can be advocating around some of these issues, and then being engaged with those of us on the call as well. We are always looking for stories. We're always looking for people to raise their voices or write letters or sign on letters or petitions. So there are a number of ways that we all work to advocate that you can join in with as well.
So this is Robin. Lori, that was extremely thorough and comprehensive. So I just have a couple of points to add to that. In terms of basic advocacy, don't forget the facility has a grievance policy and a grievance process. And so that's certainly a route to consider when advocating. Lori talked about individualized care. So think about taking this issue up at a care plan conference and talking there about the needs of the resident for, you know, a shower or for window visits or whatever else. And certainly don't forget that resident councils and family councils can also be a good avenue for addressing concerns and for advocating. Anybody else want to add to that?
This is our quick responses to assisted living.
Please.
I think that, you know, that's at this point, the nursing facility reopening is really at a state level. CMS has just issued recommendations, and like Lori said, it's up to the state to figure out how to do it and when and how to allow visitors and the whole thing. So I don't know if a resident is in, or an advocate is in that much different position in assisted living as compared to nursing facilities at this point when you're talking about reopening. There's so much being delegated to the state at this point. So the same thing is true in assisted living. These are state level decisions by and large.
And that's a really good point, Eric. This is Lori, because in looking at the guidance that's coming out from states right now, much of it applies to all long-term care settings, both nursing homes and assisted living. And in fact, for example, the Ohio visits that were started earlier this week only apply to assisted living. They don't necessarily apply to nursing homes yet. So, so being really aware of the guidance that your state is putting out and contacting your policymakers in the state about what you think should be included in those, I think is an important step to cover all of the settings.
Thank you, Eric, and thank you, Laura. The only thing I would add to that is just in terms of advocacy in assisted living, I think the points that were just raised are certainly ways to advocate in assisted living as well. Maybe there, you know, isn't necessarily a requirement that that supports resident councils, family councils in assisted living, but there's still there are lots of avenues, lots of similarities between ways to advocate in assisted living as well. So I realize we have come to the end of our time. So in closing, I want to do the thank you parade, I think. I want to once again thank Lori and Toby for providing us with some really great and important information. I want to thank Eric for helping answer questions. Thank Jocelyn and Sam for their work handling the questions. Thank Libby Lover for technical support behind the scenes. And then I want to thank all of you for taking time out of what we know are just drop dead busy schedules to be with us today. Want to remind you that next week we have number 9 in our webinar series, and ask all of you to spread the word to family members to join our free family advocacy webinar on June 18th. So everybody have a great rest of the day, a great weekend, and stay safe.
Thank you.